Our first speaker of the day is going to give us a little overview on NETs, and I want to thank Dr. Wolin because he's spoken at many of these conferences, and he's willing to do anything that needs to be done for these conferences, as are most of the speakers. But you'll see Dr. Wolin a few times during the day. He's one of the premier experts in NET. So without further ado, please welcome Dr. Ed Wolin.
Thank you. Okay, well, it's a great privilege and honor to be here and to speak with you all today. And I want to thank Bob and Marianne Wahman for making it possible, and the support group in Washington area, and all of you. It's a pleasure to be back. I actually grew up in this part of the world. It's been many, many years. I grew up in Falls Church, Fairfax County, and then we moved to Bethesda. I graduated from Walter Johnson, so I have fond memories of Washington, D.C., but I've been out of here since I was 17 years old, and it's just a pleasure to be back. Okay. In any case, what I'm going to do now is not snow you with technical data. I'm going to give you an overview of what neuroendocrine cancer is all about, so that everything that you hear today and all the other talks will be able to be put into some sort of a framework and some kind of perspective, and it will make more sense. Then later on, we'll talk about specific treatments. We'll talk about what's available today. We'll talk about new developments and new clinical trials and new things on the horizon, and all of that. But before we do, I think it's a good idea to have a basic foundation so that we all can be speaking the same language. So I'll just jump right in. This is a picture of a little piece of small intestine that is just loaded with little tiny carcinoid tumors. This particular patient had been going for years and years and years, like you just heard with Marianne Wahman, with bowel obstruction symptoms, going to the emergency room with horrible pain and vomiting, and nobody ever made a diagnosis. Nobody ever thought to look at the small intestine to see where the tumors are. Nobody thought to do a blood test. Finally, the patient had such a big obstruction, went to surgery, and instead of one tumor, there were actually about 60 tumors in the small intestine. Statistically, 25% of small intestinal neuroendocrine tumors, carcinoids, are multiple, and there actually are even more than one. Very often they're small. And this is a sneaky area because colonoscopy usually doesn't get very far into the small intestine. You can't see these things. And upper endoscopy doesn't get to this area. So you really have to be alert, because there's some special tests that we'll talk about soon that actually can look at this area. But if you don't think about it, you'll never make the diagnosis. Neuroendocrine tumors, as you've just heard, are considered a rare disease, but they're becoming much more prevalent. The incidence has increased by 500% in the last 30 years, which is astounding. Breast cancer happened to maybe one woman out of 5, 20 years, 30 years ago, and it's the same today. But neuroendocrine tumors have remarkably increased in incidence, meaning that there's something in the environment that's doing this. We have roughly the same mix of genetic backgrounds in America today that we had 30 years ago. So I think that we have to be alert to that, and research is ongoing to try to pin down the causes. The prevalence, which means how many people are running around with metastatic neuroendocrine tumor, like so many of you here today, the prevalence in the population has astoundingly increased because people are living so much longer as a result of advances in treatment. It's now the second most prevalent gastrointestinal cancer in the United States. Number 1 is colon cancer with roughly 1 million people. And number 2 is neuroendocrine cancer with roughly 100,000 people. So yeah, there are 10 times more people with colon cancer, but there are more people living in America with metastatic neuroendocrine tumors than adenocarcinoma of the stomach and pancreas put together. That's a remarkable statistic. So even though people hear about stomach cancer and pancreas cancer all the time, unfortunately, people often don't live that long with those diseases, and because of that fact, neuroendocrine cancer has become so much more prevalent. So I think even though most doctors, as you've heard, know very little about it, I think people are going to be forced to start learning a little bit more, because it's something that patients have, and people need to find out about and know how to develop a proper treatment. This is a patient-reported time between first symptom of carcinoid tumor and diagnosis, a big national study that was done, and I presented this to the gastroenterologists to beg and plead that they make diagnosis a little bit sooner. But of the 700 patients, the average person needed a couple of years before a diagnosis was ever entertained. About 34% of patients went over 5 years before they can be diagnosed, which is astounding. And meanwhile, the cancer is in the body, growing, often metastatic by the time it's diagnosed. It's really a tragic situation. And the average person sees 5 or 6 different doctors and has 13 different office visits. As you've heard, it's not only Mary Ann, but so many people in America are being misdiagnosed and being told they have irritable bowel, they're crazy, they have hot flashes, even though they're 40 years old, they're maybe going to have premature menopause because they're having hot flashes all day, and that's why they're red in the face. And it goes on with wrong diagnoses. And then all of a sudden, oh, I guess I made a mistake, it's really a carcinoid. So we have to increase awareness in the population. This is a famous graph that was made by Aaron Vinnick years ago, but I think it still gives an idea of how this cancer grows so slowly that it's in the body for years and years and years before it's even diagnosed. And at the time people start getting bad symptoms, people can deteriorate very badly if it's not treated. This is sort of a graph of what happens if nothing is done about a cancer. Nobody in this room is going to be on such a graph because by the time people are diagnosed, we have so many treatments to tremendously prolong survival. But the natural history, before people were having octreotide and lanreotide and somatostatin analog therapy, and before they were being treated with surgical cytoreduction and embolization and PRRT and all the things you'll be hearing about today, before that time, this is what happened. By the time people were diagnosed, they were almost terminal, which is amazing. Okay, now when we talk about treating neuroendocrine tumors, let's be sure that we're all on the same page and understand what we're talking about. Sure. Earl, my mouth had it. Thank you. So, is this better? Oh, okay. Thank you. So the classification of neuroendocrine tumors is rather bizarre. We have to imagine where the cell of origin would have been if it came from the person when he was or she was an embryo. Now, when you're an embryo, you have some things that develop that then turn into organs later on, but they're still in an embryonic stage. You start out with a fertilized egg and a ball of cells, and then the cells start moving around and starting to organize themselves into organs. And before they make organs, they make little clumps. So one's called a foregut, one's called a midgut, and one's called a hindgut. And those 3 clumps in the embryo eventually give rise to the adult organs. So the way these neuroendocrine tumors are classified is where the cell would have been if it was in your body at the time when you were an embryo. It seems really bizarre, but it actually has a whole lot to do with how these tumors behave, the hormones they secrete, the biology, the genomics, the response to chemotherapy. Everything depends on the site of origin it would have been if it were embryonic. So the ones that are called foregut involve things like stomach, lung, thymus, the upper part of the intestine, like the duodenum. Pancreas is technically foregut, although it's sort of a classification by itself because it's so unique, but it's in that category. The next major category is called midgut, and the midgut gives rise to most of the small intestine, and those are probably the single most common site. They're also the ones that most commonly would be a cause of carcinoid syndrome, midgut. And hindgut is the area that gives rise to the rectum and the lower part of the intestine. And those have, again, unique properties. They usually don't make any hormones. They usually don't cause any syndrome. And they have other features that are special for tumors that start in the hindgut derivatives. Okay, so the first thing is site of origin, and that's the way to think about it. The second thing to think about in talking about treatment of neuroendocrine tumors is how fast they grow. That's called grade. Grade is a completely different concept than stage. Stage means how much has the cancer spread in the body. Grade means how fast is it growing. Grade. So we normally evaluate grade, the speed of growth, by how many cells are dividing in the cancer. And there are two ways that that is analyzed. One is by counting the number of mitoses under the microscope, the number of cells we could actually see, one cell splitting into two cells, like back in the days of high school biology, where you can actually see the different phases of mitosis. And the pathologist could see that under the microscope and count up how many cells are dividing in 2 square millimeters of tissue, which is also referred to as 10 high-powered microscope fields. So that's one way of doing it. The other way of doing it is letting a computer do it, or you could manually count as well, doing something called Ki-67, Ki-67, also known as MIB1. That's another name for the same test. And this is a test on the pathology slide where the cells are treated with a chemical that makes dividing cells turn black and the non-dividing cells are transparent. So the dividing cells will jump out and you could see them sort of like black ants on a white floor. It makes it really easy to count dividing cells. And you can have a very, very large number of cells analyzed very quickly, and it gives you a more accurate number than mitosis counts. So we use both of these figures, but if you haven't had a Ki-67 determination in your pathology, it probably means the pathology department was not that sophisticated and or it wasn't aware, and that should be reviewed by somebody who's a specialist, and the Ki-67 should be determined because that's a critical piece of information. And there could be a discordance between a mitotic count and a Ki-67. The only time we don't really use Ki-67 in the same way is for ones that start in the lung. Lung carcinoids have a peculiar system of their own where the grade is determined by mitosis and whether or not there are areas of cancer cells dying from lack of blood supply called necrosis. So that's special for lung, but for gastrointestinal and pancreatic neuroendocrine tumors, the Ki-67 is a key piece of information. Now, the classification has changed about a year or so ago, and many pathologists are not even aware that this classification change has occurred. The World Health Organization changed the 2010 system to a new one in 2017 for pancreatic neuroendocrine tumors, and it's about to make the same change for other ones. The most important part of this change is what is called high grade. Neuroendocrine tumors that are grade 1 and grade 2, which are going to occupy most of the discussions of the meeting today, grade 1 and grade 2, are also known as well-differentiated neuroendocrine tumors. Well-differentiated means that under the microscope, the cells look like adult cells more than they look like cells from an embryo. They look like they have specialized into adult cells. So those are called well-differentiated. So the well-differentiated tumors are called grade 1 or G1 and grade 2 or G2. The Ki-67 proliferation rate for G1 is 1% or 2%. And when it starts getting between 3 and 20%, we call it grade 2. They're still well-differentiated, but we call them grade 2. When it's more than 20, we call it grade 3 or G3. And the terminology changes. We call it neuroendocrine carcinoma if it's more than 20 mitoses per 10 high-powered fields, and we call them high grade. Now, it turns out that this is a very, very heterogeneous group, because if somebody has a Ki-67 of 22%, it's not the same disease as if you have a Ki-67 of 97%. Okay? The one that's 97% is going to grow like a bat out of hell, and it's a really, really highly aggressive neuroendocrine cancer. And the one that has a Ki-67 of 22% is going to behave just like it's grade 2. It just happens to be a fluke that it just happens to be a little hair over the arbitrary cutoff that's being used to determine the grades. That, after all, was just made by some pathologists sitting around a table coming up with what they thought were good cutoff numbers. So there's no exact science to this. Ki-67 is a continuum that goes from 0 to 100. So finally, the WHO recognized this and has incorporated it into a new grading system. We're now grade 3, with a Ki-67 more than 20%, is split into two groups. One is called neuroendocrine carcinoma, and one is called neuroendocrine tumor. The ones that are called neuroendocrine tumor are much more favorable. They respond to the same kind of treatments like the other well-differentiated neuroendocrine tumors, and they can respond to PRRT and all kinds of treatments that are used for well-differentiated neuroendocrine tumors. So that's one category, well-differentiated grade 3 neuroendocrine tumor. The second category is called poorly differentiated neuroendocrine carcinoma. And those are very aggressive tumors. They get treated with intensive chemotherapy, sometimes immunotherapy, and it's a whole different disease from the previous. So just be aware. So if somebody tells you have a horrible high-grade tumor, let's start chemotherapy. Let's be sure the pathology report is being very carefully reviewed by somebody who understands what's going on, because it really can make an enormous difference in therapy. And it's really a tragedy, actually, to get treated with really intensive chemotherapy using platinum and etoposide, for example, that has no chance of working in a tumor where some very gentle treatments might work better and longer. So just have to be sure you're treating the right disease with the right therapy. Okay, next major concept to keep in mind is what we call functionality. Functionality means making of hormones by the tumors. After all, neuroendocrine cancers come from endocrine cells. A mutation happens in a cell that gives rise to endocrine cells, endocrine organs, and when these kinds of cells become malignant, they make a neuroendocrine tumor. It just happens in the gastrointestinal tract. These neuroendocrine tumors are scattered all over, and they're not organized in a specific organ like a pancreas or a thyroid. So they still can make neuroendocrine cancers, but you can also get neuroendocrine cancers that start in an actual endocrine organ like the pancreas. In any case, these tumors don't always make hormones, because when they become malignant, they undergo a lot of changes from normal cells, and sometimes they lose the ability to make hormones, even though that was the original job. The hormones that get made depend on where the tumor is coming from. So if a tumor is coming from a pancreas, it makes very different hormones than a tumor that's coming from the intestines. Okay. Carcinoid syndrome is the most common hormone secretion syndrome made by tumors that start usually in the intestine, usually mid-gut by our definitions before. Mid-gut neuroendocrine tumors, which include the small intestine and nearby areas. And those tumors make a hormone called serotonin, which we can measure. We can also measure a byproduct of serotonin called 5-HIAA. It can be measured in the urine, but what we do routinely now is we measure it in the blood. As collecting urine in a jug for 24 hours is not so fun, and being on a special diet that's necessary for that collection, and we can get just as good information from a blood test if it's a fasting specimen sent to the laboratory who knows how to do it. So that's a big advance in that area. But serotonin is a hormone that's made by mid-gut tumors. If you get too much of it, you can get diarrhea. And that becomes a major problem for our population. We'll be talking a whole lot more about the details of that. And serotonin seems to be the cause of that. In addition to making serotonin, these tumors make all kinds of other chemicals that are not routinely measured, including all kinds of, they have big names, tachykinins, different substances. And it's these other substances that seem to be involved in causing flushing, because flushing is also a very common symptom of carcinoid syndrome. And we'll talk more in detail about that as well. You can get scar tissue formation in the abdomen. You can get scar tissue formation in the heart that can mess up heart valves, as you'll be hearing about. So it can do a lot of different things. It can cause wheezing, and it can cause rapid heart rate, and it can cause anxiety, and all kinds of different symptoms. That's carcinoid syndrome. Now, pancreatic neuroendocrine tumors make pancreatic-type hormones, which are different than serotonin. They can make a little bit of serotonin, but not usually enough to make a really bad carcinoid syndrome. Instead, they make different hormones. Insulin is the most famous, and if you have an insulinoma, so-called, a tumor that makes insulin, your blood sugar can get very low, and you might have to eat every hour for the whole night so you don't pass out. It can be a really big problem, and these have to be aggressively treated because the symptoms can be bad. You can also have tumors that make gastrin, that makes the stomach pump out too much acid. So there are a variety of hormones, and the list here is not even complete. It's just some of the more common ones. And we often name these pancreatic tumors according to the name of their hormone. So they have names like insulinoma, gastrinoma, glucagonoma, somatostatinoma, and these are just being named for the hormone that's being made. Okay? I guess one more thing I should just mention is there are certain syndromes like MEN1, which can be associated with getting lots of pancreatic neuroendocrine tumors and other foregut neuroendocrine tumors. And there are other specialized syndromes where you can get other features, and this is in addition to functionality and location and grade, is one of the things that ought to go into consideration planning therapy, because sometimes it makes a difference if you're treating just one carcinoid or area of carcinoid, or you're treating multiple ones. Okay, so how do we diagnose a small intestine carcinoid, first of all? The best test out there, by far, is something called double balloon push enteroscopy, which most people have not heard of and most gastroenterologists don't do. This is a test where you can directly scope out the small intestine. It's extraordinary. You put in, for example, a colonoscope, and through the colonoscope you have a little skinny scope, sort of like the pediatric type scope that was described earlier on, but it's very long and it's made specifically for looking at the small intestine. But unlike just a regular pediatric colonoscope, this is one that has a balloon above the observation chamber and a balloon below, with an observation chamber in between, and then the whole works advanced up the small intestine. And the chamber in between allows you to look at the tumors that might be there. You can directly see them, biopsy, cauterize, all the things you can do with colonoscopy, you can do in the small intestine. We had a study that we did when I was at Cedars-Sinai in Los Angeles before I came to New York. And we did a large group of patients who came with metastatic neuroendocrine tumors in their liver with an unknown primary. And they had already had upper GI endoscopy and lower GI endoscopy and endoscopic ultrasound of the pancreas and all kinds of CAT scans and MRIs and had an unknown primary. And we did double balloon push enteroscopy and found a primary in 85% of that population in the small intestine. That's where it was hiding. And nobody knew. That's remarkable. So the small intestine is a very difficult place to image and to evaluate. People come to emergency rooms, as I said, with bowel obstructions that don't get evaluated. But this is really the gold standard. Now, there's some other things that can be done. There's a test called wireless capsule enteroscopy. It's not as accurate as double balloon push enteroscopy, but it's a lot more readily available and is often done before double balloon push enteroscopy. Wireless capsule means swallowing a pill camera. It's a complete camera, including a strobe flash, a radio transmitter, battery pack, everything in the size of a small pill. You swallow this thing, it goes through the GI tract, and it photographs everything it sees and sends it to a hard drive or something that you wear on your belt, and then later it can be played in the computer, and it takes a zillion pictures, and you can see most of what's going on in the small intestine. However, the camera can be pointing north when the tumor is south. Sometimes it's hard to tell if it's a tumor for sure or something else. It's not as good as doing the double balloon, but it's pretty good. And if you run into a big tumor, it'll find it. In fact, there's some big tumors where it could actually get obstructed, and then you have to have surgery to take it out. But at least you know what you're operating on, and you found the place. In any case, that's why you have to discuss these things with the doctor. There also were some non-invasive ways of looking at small intestine, which again, if you don't think of the diagnosis, you don't order the right tests and you don't find out. One is called CT enterography and one is called MRI enterography. Enterography means examination of the small intestine. And what these things are able to do are a little bit like virtual colonoscopy. You can do a CAT scan or an MRI, which has the ability to remove everything in the entire picture except the structure of interest, which is the small intestine, and everything else disappears. So all of a sudden, the thing you're looking at just stands out, like you were doing a colonoscopy or a endoscopy, and you can actually see that organ. So it makes a very good picture and often can diagnose things non-invasively. So that's another very good test. The worst thing is not to do anything. No blood tests, no radiology, you just miss the diagnosis. That's the worst thing to do. Okay, endoscopic ultrasound is a means of putting an ultrasound transducer into a upper GI endoscope, and you can actually do an ultrasound of the pancreas through the endoscope. And it shows incredible detail. It's like women get transvaginal ultrasounds of the ovaries or uterus. You can see so clearly what's going on when the ultrasound transducer is right next to what you're looking at. And that's what we're talking about here. If you put the ultrasound transducer in the stomach and look at the pancreas, which is just like right on the other side of a membrane, you can see very clearly what's happening. Okay. Now we have also the ability to do specialized imaging studies. I am a big fan of MRI for a lot of reasons. One is that it has no X-ray radiation at all. And if somebody has a metastatic tumor and is going to need to have scans every 3 months, 4 months, 6 months, maybe for the rest of their life, it's an awful lot of radiation to do CAT scans of chest, abdomen, and pelvis with contrast over and over and over. It's also hard to do a good enough CAT scan unless you really use a lot of radiation, because you have to do a triple phase CAT scan with contrast so that you can try to make a difference in the visualization of water density masses in a liver, in a water density liver. Everything can look like a same blob unless you have a different blood flow in the tumors from the cancer itself. Sorry, the different blood flow in the liver and in the cancer. So CTs are great, but it isn't something to repeat over and over and over and over if you could do an MRI. So in addition, there is a technique of MRI which is amazingly good for liver metastases, which is a biggie for neuroendocrine tumors. They tend to go to liver very quickly, and it's called Eovist. Eovist is a contrast agent which is injected intravenously, and then it gets excreted into the bile ducts very quickly, into the bile ducts. So you end up with opacification of your arteries, your veins, and your bile ducts. And with that combination, you can see the tiniest little liver metastases, and you can evaluate whether they're living or dying or what's happening, and you have so much more information than you do with a normal gadolinium contrast, which is done for MRI. So this is a very, very good technique and something we do very routinely. Okay. The other thing which we'll be talking about later is the gallium-68 dotatate PET CAT, which goes by the nickname of NET spot. This is a test where a radioactive somatostatin analog, it's sort of like a radioactive octreotide, is injected intravenously. It goes to the tumor and attaches to the tumor cells and sends out a ray, so you can say, here I am, I'm a tumor, and localize where the tumor is. It not only tells you that the tumor has somatostatin receptors and can respond to things like octreotide and lanreotide, but also can tell you that it might respond to PRRT. It's a very valuable test for diagnosis and a very valuable test if it's going to make a difference in therapy. It's not a substitute, however, for an MRI or a CT, because you cannot measure tumor size on a PET scan. You can only say it's there, and you can say how intense the brightness is, but you can't measure size. So if you want to see if your tumor is responding to therapy, you need to get another CT or MRI. So that's why I think it's a mistake to get these things over and over and over. I've seen some people just getting them every 6 months routinely or every 4 months routinely. In most cases, that's not really the best way to do it, because you can't measure the tumors anyway unless you get cross-sectional imaging, meaning an MRI or a CT, where you can make measurements. Okay, so that's really the fantastic test. Probably a gold standard for detecting neuroendocrine tumors when it's positive. Needs to be done and read by people that are experienced, because there are lots of normal things in the body that can look like they're positive, and it's really just somatostatin receptors on normal parts of the body. So you really have to understand how to read them, but if it's read properly, done properly, it's an extremely valuable additional test, something that we do quite routinely. And we'll talk more about that later. Okay, pancreatic neuroendocrine tumors, as I said earlier, don't make serotonin usually. They make other hormones, and the functional ones make all of these hormones. Most of the non-functional pancreatic tumors also make something called pancreatic polypeptide, We normally call them non-functional, even though they're making all of this pancreatic polypeptide, because it usually does not cause symptoms. A few cases it can, but not in most cases. Okay. There also are tumor markers that are routinely checked, serotonin and its metabolites. And as we talked about for carcinoid tumors, there's something called chromogranin A, which is very widely used, but also very widely misused because it's extremely difficult to interpret. And there are about 25 common things that make it become elevated by taking one pill of an over-the-counter proton pump inhibitor like Prilosec or Prevacid or Protonix or Nexium or any one of those. Even one pill can make the chromogranin get really high, and all kinds of other things can as well. So it's really problematic. There's another one called pancreastatin, which is better than chromogranin and is often positive in neuroendocrine tumors. We follow that. But nothing is better in somebody with metastatic disease for telling if the tumor is getting bigger or smaller than a really good MRI or CT. Okay, we talked about this. Okay, so who with a red face has a likelihood of having a carcinoid tumor? And who with a red face is having just a red face or have other causes that go all the way from blushing to menopausal hot flashes and allergies, reactions to face creams, all kinds of things can make faces red. Okay? So what is carcinoid flushing? The hallmark of a carcinoid flush, these are tumors that typically start in the small intestine, but sometimes they can come from lung or ovary or kidney or other things, but the most common single place is small intestine. The flushing is without sweating. Okay? The things that stimulate the red face and sweating makes you think of other things like histamine, like hot flashes, like blushing. You get red as well as sweating, because the sweat glands are stimulated at the same time as the blood vessels. The red face comes from dilation of blood vessels. That's what it comes from. But the face and the neck have the thinnest skin in the whole body. So because the skin is so thin, the blood vessels under the skin show more clearly, and the face looks red before the rest of the body does. If it's bad enough, your whole body will look red. But the face and neck always come first. It can be associated with burning and warmth, rapid heartbeat. A lot of other symptoms come at the same time usually. It can also be associated with diarrhea. And it's not a chronic redness that's existing all the time like rosacea, but rather a redness that lasts for a couple of minutes and goes away. It's just very quick onset, very intense. Your friends will want to call the paramedics, and before they have a chance to, it's gone. This is a picture of a carcinoid flush. You're looking normal 1 minute, and the next minute you look like this. And then 2 minutes, 3 minutes later, it can go away. That's a carcinoid flush. Anybody who has such a thing should have their tumor markers checked ASAP. Okay, carcinoid diarrhea is a peculiar kind of diarrhea that has to be distinguished from irritable bowel and inflammatory bowel disease and tons of other things that cause diarrhea. It's a secretory diarrhea, meaning the intestines just keep pumping out fluid, often a lot of fluid. And because they are pumping out fluid all day, it doesn't matter if you're even drinking fluid, it'll come out anyway, or eating. It'll just keep making it. It'll just make you get dehydrated. But the fluid keeps coming into the intestine because it's a secretory diarrhea caused by the hormone serotonin. And there are ways of figuring out if it's a secretory diarrhea or not that physicians should be familiar with. You'll be hearing a lot more about carcinoid syndrome heart disease later on when Dr. Zaks is going to talk about that specific subject. But just be aware that serotonin causes scar tissue. Tremendous problems with scar tissue in the heart. Can ruin the heart valves, most commonly the tricuspid and pulmonary valves on the right side of the heart, but other valves as well. I won't talk more about that right now, but you'll be hearing a lot more. But in addition to scarring heart valves, you get the same kind of scarring in your abdominal cavity if you have an abdominal carcinoid tumor. I'm using carcinoid as a nickname for well-differentiated neuroendocrine tumors of the GI tract because it's so much easier to say. But the pathology reports now all say neuroendocrine tumor. They don't say carcinoid. But it is a carcinoid. It's the same thing. Okay, so you get diffuse scarring in the abdomen. This is a big problem because the scarring can block intestines. And people can have intestinal obstruction after surgery when the tumor's already been taken out, just from these little tiny amounts that are in the abdominal cavity. And even small amounts of tumor can make large amounts of scar. You can also get scarring behind the abdominal cavity, what we call retroperitoneal fibrosis, and that can block off the tubes from the kidney, the ureters, and they have to be reinforced to keep them open. It can also block blood vessels that go to the intestine, which is extremely serious, because that's where the intestine needs its blood supply to stay alive. When serotonin is made in the body, it uses up an amino acid, a normal part of your diet, an amino acid called tryptophan. Tryptophan gets turned into serotonin. And if the serotonin is all being made out of the tryptophan you're eating, there's not enough tryptophan left over to make the vitamin niacin, which is necessary for your health. And if you don't have enough niacin, you end up with a vitamin deficiency disease called Pellagra that people think could only happen in the most impoverished third world countries. But we see Pellagra in people with carcinoid syndrome in America because they don't have enough. Pellagra causes a red skin and it causes diarrhea, and people can blow it off as part of carcinoid syndrome, but it's a chronic redness. The skin is thick and scaly. It's not the same kind of redness that you get from carcinoid, and you can get diarrhea. You can also have mental status changes, and it's not a good thing to have at all. And it's so easy to treat. You just can take a niacin supplement. I recommend no flush niacin, because otherwise if you take niacin, it's going to make you flush and you'll think you have a carcinoid attack. And you can also just eat more protein that has more tryptophan in it. If you keep flushing all the time and don't treat your flushing, and you're always flushing, you could end up with chronic flushing. The blood vessels in the face and neck stay dilated and don't go down anymore. And when that happens, you have a condition called rosacea. Rosacea just means your face is just red all the time, and that is more problematic cosmetically. Okay, so we treat the causes of this. Rosacea is also more common in stomach carcinoids, where histamine is prominently made by the carcinoid rather than serotonin. It's a foregut carcinoid. Okay, you can have problems with nerve function, making muscle weakness, which I've seen from carcinoid. People get diabetes. They get diabetes pretty easily if the neuroendocrine tumor starts in the pancreas, which of course is where insulin is made. But even people with carcinoid tumors elsewhere often get diabetes. And octreotide and lanreotide, which are mainstays of therapy that I'll be talking about later, those therapies also raise blood sugar in some people. So blood sugar should always be monitored, and if individuals can't control it with diet, they sometimes need a pill, or in rare cases insulin. Or if somebody already has diabetes, the diabetes might get worse. So just another thing to be aware of. Okay. Vitamin B12 deficiency is more common than people realize, and it's a serious condition because the average person who has an intestinal carcinoid tumor, which again is the single most common site for these tumors to arise, has their end of their small intestine and beginning of the colon removed. It's called a right hemicolectomy or ileocolic resection. There are different names for it. But when you do that kind of thing, you get rid of the end of the small intestine where vitamin B12 gets absorbed. And as a result of that, you could end up with a deficiency of B12 that not only causes a severe anemia like pernicious anemia, but also can damage the nervous system permanently. And that's the most serious thing that can happen, is the neurologic damage. So it's very important to monitor B12 levels in anybody who's ever had a right hemicolectomy or had their end of their small intestine removed. It's so easy to measure B12 levels in the blood. Just don't let yourself get deficient. Okay, and one more thing about carcinoid syndrome that might be worth mentioning is that not everybody who has a carcinoid and has diarrhea has carcinoid syndrome. one of the problems is that we've talked about how small intestinal neuroendocrine tumors can make hormones, but in addition, when you lose the end of your small intestine, when you have that type of surgery, a right hemicolectomy, for example, you lose the ileocecal valve, which is a one-way valve that connects the small intestine and the large intestine so that whatever intestinal contents only flow forward and not backward. It's a flap valve. That's the liquid in the small intestine go into the colon, but it doesn't let feces back up into your small intestine. You lose that valve when you have surgery for carcinoid, and as a result, feces can back up into the small intestine, and the bacteria which live in feces start growing in the small intestine. You have what's called bacterial overgrowth syndrome, which causes terrible diarrhea, doesn't respond to somatostatin analogs, doesn't respond to anything except for using a non-absorbable antibiotic that will kill the bacteria that are causing this. So you have to make a specific diagnosis. You can also get a terrible diarrhea from not absorbing bile acids properly, bile salts. So if that's the case, you can take bile salt binders and it can stop diarrhea, but again, they won't respond to other things. There are many things, infectious causes of diarrhea. So if somebody has, you can have a short gut because your intestine has been removed and there's not as much room for absorbing water. So there are a lot of different things that can make diarrhea, so you really need to be evaluated by somebody who knows what is happening, and be sure you treat other competing causes of diarrhea, and don't just think the only possible treatment is treatment of carcinoid. And treating carcinoid diarrhea is actually a specialized area. We'll be talking about that later with somatostatin analogs and telotrestat and other modalities. Now, how do we approach the treatment of carcinoid tumors? I'm going to give you, again, just a basic overview that does not include medications, because we're going to be talking so much about medications later on. I'll tell you about therapies that are going on now and in trials. But just remember that medications are not the only way to treat carcinoids. In fact, surgery is key. Anybody who has a neuroendocrine tumor that can be taken out should be taken out. That's by far the number one best treatment there is. It's the only treatment that has a chance of cure when cure is possible, and it gives you the best chance of long-term palliation if you get all the tumor out of your body. So that's a good thing. We'll be hearing more about that from surgeons. Okay, so surgically remove all possible tumors from the liver, abdominal cavity, intestines, if it's technically possible. Not the case in everybody, but in certain people it is. And if 90% or more of the tumor can be taken out, some people might say even 70%, but especially 90%, it can be taken out. The results are very good. It's been associated with a longer survival. And I'm sure that a very large number of the people here who said that they were living with carcinoid for 20 plus years have had aggressive treatments of their carcinoid tumors to reduce the volume. And surgery is certainly one of the major considerations in reducing the volume. And we have other things as well. Surgery is not for everybody. For metastatic disease, it is for everybody who has localized disease who's operable, but in selected patients, it's a terrific procedure. So just be aware. Anytime a surgeon does surgery in the abdomen on somebody with a metastatic neuroendocrine tumor, they need to be reminded to take out the gallbladder, because unless they're into carcinoid surgery, they don't think of it. Because if you don't take out the gallbladder, you have at least a 50% chance of getting gallstones from taking octreotide or lanreotide, and might need an emergency operation later. So if you're in there anyway, and it's not going to increase the risk of the surgery, you take out the gallbladder and just put it in a bottle. Also, sometimes people need embolization treatments of their liver, and the artery to the gallbladder often comes off the artery to the liver, and you could end up getting embolization in the gallbladder by mistake, and if that happens, you end up having, again, emergency problems with cholecystitis and needing to have surgery in the gallbladder. So if you already had surgery and your gallbladder did not come out, definitely don't go back to surgery to have your gallbladder taken out. I'm not suggesting that that be done, because then it's a whole other surgical procedure and it's not worth the risk. And then if you haven't had it out initially, you just wait until you have a problem, and then if you do, it can be taken out later. But if you're in there anyway and can prevent a problem, why not? Okay. Another excellent modality for treatment is using what we call hepatic artery embolization. The liver is the most common place where tumors go if they get into the bloodstream and they start from small intestine or pancreas. And the reason is that the circulation in those organs is different than everything else in the body. Most of the body is sort of like you learn in 3rd grade, where you have a circulatory system where the heart pumps out the blood through an artery and it goes back to the heart through a vein. That doesn't work that way for small intestine and pancreas. The blood comes from an artery, but it never goes back to the heart through a vein. Instead, it goes to the liver through a bypass tract to get filtered. That's the way it works. The liver filters the blood that comes out of the pancreas and the small intestine. It takes out all kinds of goodies. It stores up carbohydrates for a rainy day. That's what's called glycogen. That's why people carb load before a marathon, because the liver is storing up those sugars when you aren't eating. And it also can detoxify a lot of things. It's a good thing to have this filtration system. But that means that if a cancer cell gets into the blood from the small intestine or liver, it's a straight shot to the liver. Okay? If a tumor is in the small intestine or it's in the pancreas and it gets in the blood, next thing you know, it's stuck in the liver. And it gets jammed up in the filtration system and it doesn't get out so easily. So that's why in these tumors you can see 25 liver metastases and nothing else anywhere in the body, or some little itty-bitty tumor somewhere in a bone, but almost everything is liver. And that's why so many treatments are directed at the liver. And we can do liver surgery, we can do ablation, you can stick a probe into a tumor and microwave it. You can do procedures where you block off the blood supply. It's called hepatic artery embolization. And that's what this is, hepatic artery embolization. You could block off an artery and even put in chemo or radiation at the same time. We're discouraging use of radiation for this use because it can interfere with later PRRT. It increases the risk of liver failure. But you can do the embolization with just blocking the blood vessels alone. It's done with a catheter in the radiology department with minimally invasive procedure, or sometimes it's done with chemotherapy. And in fact, we're doing a randomized trial of chemotherapy embolization versus planned embolization to try to determine which one is the better way to go. But we don't have an answer to that yet. Okay, and like prolonged survival happening when people have surgery, people have also demonstrated prolonged survival when tumors are reduced in volume with embolization. It's a good procedure. And like everything, it has its risks and its potential benefits. Okay, so again, after I discuss all the different kinds of therapies in more detail, and you hear from other speakers about all different kinds of therapy, we'll talk about how to put it together. But the bottom line is that every single week we have a neuroendocrine and carcinoid tumor conference, and all of these specialists are represented at our conference. And we actually all look together at the pathology and the radiology and discuss the management and get inputs from different directions, because it's really sometimes a very major challenge to determine what is the best sequence of therapies. Should the patient be treated with a systemic therapy like PRRT? Would it be better to do embolization first and say PRRT for another day? Is it better to do surgical cytoreduction? To have all the specialists in one place talking about the risks and benefits of each of these procedures and try to prioritize what is in the patient's best interest is extraordinarily valuable, because there's no one person who has total command of all of these different disciplines. So that's why we have a multidisciplinary team. In any case, it was a great pleasure speaking with you about all of this, and I'll be talking to you later. Thanks so much.